So with chapter 18, we're talking about another vulnerable population, specifically children, and how we need to incorporate plans to address the special needs of children and youth in emergency planning and preparedness. Children make up roughly 23% of the US population. They have unique biological, developmental, and psychological characteristics that make them especially vulnerable during disasters and public health emergencies. Yet, pediatric needs are often overlooked in emergency planning, which can result in preventable harm. Children are not simply small adults. They require specific considerations in triage, medication dosage, equipment, decontamination procedures, and shelter design. Planning must also address unaccompanied minors and establish clear unification processes with caregivers. Creating a pediatric disaster plan is not enough. It must be tested through drills. If weaknesses are identified, the plan should be revised and exercised again. Effective preparedness for children requires intentional planning, realistic testing, and continuous improvement to ensure that pediatric victims are adequately protected when disasters happen. Although children make up nearly one quarter of the US population, disaster planning has historically underprepared for their needs. Children are uniquely vulnerable, yet many response models are still built around adult assumptions. Adult disaster frameworks do not translate well to pediatric care. State and federal plans often lack consistent provisions for children, even when supplies exist. Communities may not have adequate quantities or training necessary, particularly if pediatric specific drills have not been conducted. Children differ developmentally, physiologically, and psychologically. These differences increase because their physical and mental health risks uh, are severe during disasters. They are especially vulnerable in traumatic events and in incidents involving nuclear, biological, chemical hazards. Pediatric preparedness cannot be an afterthought. It must be intentional, practiced, and adequately resourced to truly protect those in need. And this table here is showing the unique characteristics of children at different developmental levels from infancy all the way to 18 years of age, highlighting some of the unique characteristics of children in those different age brackets. Children with special health care needs are among the most vulnerable populations in disasters and public health emergencies. Many rely on complex medical care and equipment that requires electricity, such as ventilators, oxygen, feeding tubes, tracheostomies, and parenteral nutrition. Even short disruptions to power, transportation, or access to care can become life-threatening for this population. Their medical management is often highly specialized and documented across extensive records. If responding clinicians do not have immediate access to those records, critical aspects of care can easily be missed. This is why families should be encouraged to work with healthcare providers to complete an emergency information form or EIF. The EIF provides a concise summary of the child's diagnoses, medications, equipment, and emergency care needs. In a crisis, especially when care occurs outside the child's usual facility, the EIF can make a difference between fragmented care and safe, coordinated treatment. In this table, we see a description of some of the physiological characteristics of children that are unique to them as compared to adults that potentially have implications for not only right routine medical care, but also especially during disaster situations. In addition to physical health concerns, children have significant mental health needs during disasters. They do not process events the way that adults do, and disruptions can deeply affect their emotional and developmental stability. In chaotic situations, especially when caregivers are injured, missing, or overwhelmed, children are at heightened risk for neglect, abuse, and long term psychological harm. Supporting children requires more than medical care. It requires access to social workers, psychologists, and community based protective services. Children may also regress under stress. They may not understand what's happening. They may become withdrawn or silent, may lose previously mastered skills such as toilet training, and are highly sensitive to adult anxiety around them. Recognizing these behavioral and emotional signals is essential. Protecting children in disasters means addressing both their physical safety and their psychological well being. In the past, disaster planning largely overlooked children. Early response models were built around military frameworks but focused primarily on healthy adult populations. As a result, pediatric needs were not systematically incorporated into disaster plans. Recent disasters have made it clear that children require dedicated planning. Once pediatric disaster plans are developed, they must be tested to identify gaps and implementation challenges before a real event happens. Research from healthcare facilities in Los Angeles County found that most did not include children in disaster drills. While tabletop exercises are helpful, live drills more effectively test real world readiness. Including children in drills, such as partnering with community groups like scouts or youth sports teams, adds realism. With scripted victim cards, responders can practice pediatric triage and care under realistic conditions. If we don't test pediatric plans with pediatric scenarios, we can't assume they will ever work when children's lives depend on them. The Hospital Preparedness Program, or HPP, began in 2002 to strengthen hospital readiness for public health emergencies and bioterrorism events. By 2004, it shifted to an all hazards approach, emphasizing collaboration and hazard vulnerability assessments. In 2012, HPP aligned with the Public Health Emergency Preparedness Program to streamline overlapping goals. But planning isn't just about systems, it's also about people. Children's needs must be integrated into the planning phase, including childcare considerations, spiritual and family support, and building youth resilience. The Institute of Medicine emphasized expanding stakeholders involved in pediatric preparedness. That means going beyond traditional responders and including schools, child care centers, faith based organizations, youth groups, healthcare systems, EMS, police, and public health. Plans should be shared across agencies to eliminate gaps or duplication. Roles must be clearly defined before disaster strikes, and memoranda of understanding should already be in place. Effective pediatric preparedness doesn't happen in a silo. It's coordinated, collaborative, and community driven. During disasters, public health emergencies alike, children may arrive at the emergency department without a parent or a guardian. Younger children often cannot provide identifying information. They may only know mom or dad and may not know their address or phone number. Children with special health care needs may struggle to communicate, and infants obviously have no verbal ability at all. Because of this, healthcare facilities must have clear identification and reunification procedures in place. This includes identifying unaccompanied minors, whether injured or well, attempting to contact parents or guardians, tracking the child within the facility, safely housing uninjured children, and ultimately ensuring reunification with the correct caregiver. Intake documentation should be thorough, detailed physical description, clothing, distinguishing features like birthmarks, where the child was found, anything the child said, and photographs to assist with identification. Without a structured process, reunification becomes chaotic. With one, we increase the likelihood of quickly and safely reconnecting children with their families. The Unaccompanied Minors Registry is a centralized system for logging, identifying information on children separated from caregivers during disasters. It is overseen nationally by the National Center for Missing and Exploited Children, and all unaccompanied minors should be entered into the system to support tracking and reunification. Within healthcare facilities, each child should receive a secure identification number, typically through a wristband that cannot easily be removed. This ensures that children can be tracked within the facility and, if necessary, during transfer to another facility. Clear documentation must accompany any transfer to support eventual reunification. Facilities should designate a secure child-safe area with a single monitored entrance. Staff assigned to this area must be vetted in advance. The space should be child-proofed, appropriately staffed, and equipped with age-appropriate activities, food, clothing, and infant supplies such as cribs and formula. Finally, children should be shielded from media coverage of the event to reduce additional trauma. Effective registry use and structured facility procedures are critical to protecting children and ensuring safe reunification. In any disaster, a designated triage area must be identified in advance with supplies ready, like tents, cots, medical packets, and treatment materials. Most triage systems use a color-coded structure like green for minor injuries, yellow for urgent but not life-threatening, red for life-threatening injuries, and black for non-survivable injuries, which should be managed in a separate area. Facilities must clearly determine which triage protocol they will use during a surge, avoiding under triage, missing critical injuries, and over triage, misclassifying minor injuries as severe. This is essential for effective resource allocation. For adults, START is commonly used. For children, Jumpstart was specifically developed. It rapidly assesses appearance, breathing, and circulation. Staff must be trained in Jumpstart and must continually reassess pediatric patients as children can decompensate quickly. Pediatric specific education is critical. Children may be frightened, unable to communicate clearly, or physiologically different than adults. Without proper training, providers may overlook injuries or misclassify severity. Effective pediatric triage requires preparation, training, and ongoing reassessment. A nationwide survey conducted in 2003 assessed emergency department preparedness for pediatric emergencies. The response rate was only 29%, and only 6% of responding EDs had recommended pediatric supplies and equipment. The median pediatric preparedness score at that time was 55. A follow-up study in 2013 showed improvement. The median preparedness score increased to 70, and availability of recommended supplies improved. However, important gaps still remain. One major challenge in pediatrics is medication dosing, which is weight-based. In emergency situations, estimating a child's weight quickly can be difficult. The Broslow tape helps address this problem. It's a length-based, color-coded tool that links to a child's height, pre-calculated medication doses, and appropriately sized equipment, particularly helpful for providers who don't routinely care for children. Beyond medications, pediatric readiness also requires smaller airway equipment, catheters, masks, and IV supplies, basic items like cribs, gowns, and diapers. Pediatric preparedness is not just about protocols, it's about having the right tools and the right sizes at the right time. Decontamination is especially challenging for children. Young children often cannot understand instructions, and the process can be frightening and overwhelming. Because of this, it is critical to keep families together whenever possible. If parents are not severely ill or injured, they can help guide or comfort their children through this process. While the overall decon steps are similar to adults, adjustments may be made based on children's age and developmental level. Infants require complete hands-on care from disrobing to showering. After decontamination, they must be dried and dressed quickly to prevent hypothermia. Staff and caregivers must keep infants warm and protected from the cold. Children are also at higher risk from hazardous materials because they absorb toxins more rapidly than adults. They are closer to the ground and may have greater exposure as well. Pediatric decontamination is not simply a scaled down adult process. It requires developmental awareness, family centered care, and careful attention to thermal and toxic risk. When disasters strike, children may be separated from their parents and arrive at shelters from a variety of settings like child care centers, schools, or even directly from their homes. During Hurricane Katrina, for example, some children were airlifted to safety while their parents were transported to shelters in entirely different states. Because of this, it's critical to ensure that children are placed in safe, supervised environments and not cared for by volunteers who have not been properly vetted. Family information centers may be established by local agencies to help manage reunification and provide structured support. For example, Los Angeles County EMS has developed a planning guide to support FIC implementation. Within shelters, children may also need structured, age-appropriate activities. Many will not fully understand what's happened and may experience heightened stress. Activities can help distract them, reduce anxiety, and restore a sense of normalcy. Protecting children in disasters requires safe supervision, organized reunification, and intentional attention to their emotional well-being. Reuniting children with their parents must be a planned process, not an improvised one. Facilities and agencies need reunification plans in place before a disaster occurs. As we saw during Katrina, some children were separated from their families for months, creating profound emotional trauma. While social media can help reconnect adults, locating and verifying children is far more complex. Facilitators play a key role. Older children may be able to provide identifying information, such as parents' name, address, or phone number, while younger children often cannot. Staff must gather as much information as possible and carefully verify the identity of anyone claiming the child to ensure safe reunification. There must also be contingency plans in place if parents are seriously injured or deceased, which may require involvement of social services or child protective custody agencies. At the national level, the National Center for Missing and Exploited Children supports the reunification of unaccompanied minors. Reunification is not just logical, it's child protective priority. During the early days of the COVID-19 pandemic, it was believed children were minimally affected. However, we soon learned they responded differently than adults. Early reports showed that most infected children had household exposure, and only a small percentage were symptomatic. The indirect pediatric impacts were profound. Schools closed abruptly, exposing major inequities in access to online education, meals, and child care. Families face financial strain, increased stress, and in some cases, heightened risk for domestic violence. Social isolation intensified anxiety and depression, particularly among adolescents. Healthcare access was also disrupted. Routine immunizations declined, pediatric hospital census dropped, and adult hospitals experienced severe PPE shortages. A new condition known as multi-system inflammatory syndrome was seen in children. Its emergence highlighted that children were not immune to serious complications. Local health departments responded with contact tracing, targeted outreach in vulnerable communities, school closures, and ongoing surveillance reporting to the CDC. COVID-19 demonstrated that even when children are not the primary victims of the disease, they experience significant medical, social, and psychological consequences that must be addressed in emergency planning. Multisystem inflammatory syndrome in children, or MISC, is a serious inflammatory condition that can affect multiple organs, including the heart, lungs, kidneys, brain, skin, and gastrointestinal system. While the exact cause is still not fully understood, many children diagnosed with MISC have either tested positive for COVID-19 or had known exposure. Although it can be severe and in rare cases fatal, most children recover with appropriate medical care. Symptoms can resemble the COVID-19, such as fever, fatigue, nausea, and vomiting. However, MISC often includes a distinctive rash and inflammatory features similar to Kawasaki disease. Certain warning signs require immediate medical attention, like difficulty breathing, persistent chest pain, new confusion, and inability to stay awake, bluish lips or face, and severe abdominal pain. Diagnosis may involve blood work, chest x-rays, echocardiograms, and abdominal ultrasounds. Some children require hospitalization for close monitoring. Treatment is largely supportive and tailored to children's symptoms. MISC reminds us that even when children appear less affected by a virus initially, serious secondary complications can emerge. This slide illustrates how COVID-19 response aligns with the core public health functions, the essential public health services. Monitoring health status. Local health departments track pneumonia cases to determine whether they were COVID related. At the same time, they had to anticipate secondary impacts such as declines in routine immunizations and potential resurgence of vaccine preventable diseases. Frontline staff collected surveillance data while program management monitored guidance from the WHO and CDC. Surveillance systems were developed. Communicating findings to federal agencies was top priority. And then, secondly, diagnosing and investigating health problems as an essential public health service, where public health departments initiated contact tracing for confirmed cases and continued monitoring for outbreaks. This required applying epidemiologic methods, selecting appropriate data collection tools, and interpreting findings to guide policy and practice. Informing, educating, and empowering the public, the next service. Public service announcements promoted social distancing and mask use. Schools and universities shifted to remote learning. Community forums were held through schools, faith communities, and other partners. Frontline staff reinforced prevention messaging, while program leadership coordinated consistent communication with community leaders and school districts. Together, these actions demonstrate how core public health functions were operationalized during the pandemic response. Looking at the additional essential public health services that were used during COVID, talking about mobilizing community partnerships, programs and grants were developed to ensure children and families continued receiving meals through schools. Nonprofits, faith-based organizations, school districts collaborated to distribute the food. Health departments even partner with librarians to assist with contact tracing. Frontline staff worked directly with families in need, while program management applied for federal grants and coordinated services across agencies. This reflects coalition building and advocacy in action. Developing policies and plans. As the pandemic evolved, public health departments continuously revised their response plans and created tiered reopening strategies. This required balancing ethics, evidence, and stakeholder engagement. Frontline staff ensured consistent messaging, while leadership identified new partners and updated policies as new scientific information emerged. Enforcing laws and regulations. Quarantine orders, stay-at-home mandates, and temporary closures of beaches and trails were implemented to reduce transmission. These actions required systems thinking and coordination across agencies. Frontline staff assessed community-level impacts, while program management worked to ensure policies were equitable, enforceable, and clearly communicated. Together, these efforts demonstrate how public health systems adapt, collaborate, and lead during a complex emergency. Linking people to needed health services. Many community members avoided emergency departments, even for serious symptoms like heart attacks or stroke, while others lost insurance, housing, stability, and basic resources. Public health responded by promoting telehealth, pushing clear, don't delay care messaging, and building partnerships to connect families to food, shelter, and supports, especially ensuring kids had devices and Wi Fi to stay connected to school. Supporting a competent healthcare workforce. Many providers, isolated from their families and systems, work to share best practices, provide training, and coordinate resources like personal protective equipment. Frontline teams supported local hospitals while leadership addressed gaps across facilities and prioritized worker well being. Evaluating services and systems. Agencies tracked cases, testing, and deaths, monitored well care and ill care utilization, strengthened efforts to counter misinformation, while reinforcing consistent public messaging and promoting vaccination access. And finally, research and innovation accelerated, treatment evidence evolved quickly, vaccine trials launched, and public health monitored emerging findings while planning distribution and communication to the public. Public health emergency planning must intentionally incorporate children. They are not simply small adults. Their size, physiology, development stage, and dependency all require specific consideration during the planning phases. Preparedness also begins at the family level. Families should create emergency plans that actively include children in the discussion. Emergency kits should contain comfort items, age appropriate activities, and pet supplies if needed. Children should know their address, parent names, and phone numbers. Families of children with special health care needs should obtain an emergency information form from their provider. Annual home drills, good hand hygiene, routine vaccination, and keeping sick children at home are simple but critical protective measures. Even enrolling teenagers in CERT training builds community resilience. Healthcare organizations must also integrate pediatric considerations into disaster plans and drills. Community-wide planning should involve schools, daycare centers, and child-focused partners. Ultimately, disaster and public health emergency plans that account for pediatric needs are essential to protecting one of our most vulnerable populations, which is our children.